So we left off here talking about the respiring tissues, the diffusion of gases. We introduced this idea of the partial pressure gradients. The gradients for the gases themselves. Remember, the gases have individual partial pressures that dictate their individual movement in different direction across the pulmonary capillary beds as well as the systemic capillary beds. All right. So what we're going to get into here is really describing further those different partial pressures and the direction of those gradients, which is the oxygen or even the CO2 cascade. How does oxygen move because of that gradient created? So first off, we have the partial pressure of oxygen in the cells. We describe it as being lower than it is in the systemic arteries and especially lower than it is in the alveolus. So at the tissue level, the partial pressure of oxygen is about 40 millimeters of mercury or lower. The systemic arteries, the partial pressure of oxygen is about 100 millimeters of mercury. So we can see that gradient existing from the systemic arteries down to the cells, which is the direction of oxygen diffusion. So oxygen diffuses from its high partial pressure of 100 into the cellular tissues or the cells within the tissues because of that lower partial pressure of 40 millimeters of mercury. Meanwhile, in the systemic veins, again, going back towards the heart, the systemic veins have a partial pressure of oxygen of 40 millimeters of mercury. So we can see that between the cells and the systemic veins, there is no gradient. So oxygen is no longer diffusing between the systemic veins and the uh, the cells. So after it leaves the capillaries in the systemic tissues and it's going back towards the right side of the heart, there is no gradient, so there is no longer any diffusion. The other gas that we're considering here, partial pressure of CO2. CO2 is also moving, but in the opposite direction because it has a partial pressure gradient that is in the opposite orientation. So partial pressure of CO2 in the cells is 46 millimeters of mercury or higher, right? Around about 46 millimeters of mercury. In the systemic arteries, it's going to be lower at 40 millimeters of mercury. So we can already begin to again predict here the diffusion gradient for carbon dioxide is from the cells where it's being dropped off into the systemic arteries. And that is where it can be diffused back into those vessels, and then that can be returned to the heart and then the lungs for reoxygenation. So carbon dioxide diffuses from the cells into the blood. Oxygen diffuses from the blood into the cells. And then again, looking at the value, the partial pressure in systemic veins is 46. So it's about the same as it is in the cells, meaning that as that blood is going back to the heart, once again, there is no gradient for diffusion. All right, so our gradients typically exist along the systemic arteries and then to the systemic tissues and the cells within those tissues. Let's talk about the metabolic demand. So within our mixed venous blood, the amount of oxygen and CO2 exchange is dependent upon what the metabolic activity at the tissue level is. We kind of talked about this idea when we looked at things like active hyperemia, reactive hyperemia with the vasculature. Here with the gases and their exchange is a similar phenomenon. The greater metabolic demand, let's say you're exercising, or you're a pregnant woman who has higher metabolic activity, metabolic demand, there's going to be greater exchange of these gases at a faster rate because of that higher tissue demand, meaning that there's going to be faster usage of oxygen and then faster delivering of CO2 as well. Now, in terms of the direction of flow, that blood is going to undergo exchange the capillary bed. As it moves back towards the systemic veins, it's going to the right atrium, then the right ventricle, then the pulmonary artery. Then it's going to be mixed in all of these areas, right? Especially the pulmonary artery. So we're going to find oxygen and CO2, both with their differing partial pressures, mixed in that pulmonary artery, which is in that venous blood that's going back towards the lungs. So again, the partial pressure of oxygen being 40, same as it was in the capillaries, so there's no longer diffusion. Partial pressure of CO2 being 46, again, same as it was in the capillaries, so there's no longer diffusion in these in the mixed venous blood here. What are some of the factors that affect the partial pressures, the alveolar partial pressures? And so the alveolar partial pressures are going to be, again, where we see a gradient between the atmosphere and what's happening in the alveolus, which is what facilitates the diffusion for oxygenation at the lungs and for dropping off CO2 also happening at the lungs. There are three important factors that affect the alveolar partial pressures. One is the partial pressures of the gases in the inspired air. And this can, to a very small extent, be determined by your elevation, whether you're at a place that's very high above sea level, very low compared to sea level. That will determine the individual partial pressures of the gases. We talked about how above sea level partial pressures go low. So if you're at a very high elevation, the partial pressure of your gases will drop somewhat. And then that can determine the partial pressures in the alveolus themselves, right? The other factors are going to be your minute alveolar ventilation. How fast are you bringing air in? What's the rate of your ventilation, the rate of your breathing? And the third factor is the rate at which respiring tissues are using oxygen and producing CO2, which is dependent upon the metabolic demand. Okay. Now, the most critical of these three factors between the partial pressures of your gases in the inspired air, your rate or minute alveolar ventilation, and then the metabolic demand, right? The rate at which you're producing oxygen, producing CO2 or using oxygen. Of those three, the most critical is the third, the metabolic demand, as well as your minute alveolar ventilation. So the second two factors here, but especially the third, are going to mainly determine your alveolar partial pressures. Okay, let's talk about some terminology when it comes to delivering of gases and ventilation. First off is hyperpnea. Hyperpnea is increased ventilation due to an increased demand. With hyperpnea, you're not necessarily changing your rate of breathing, okay? And again, this can be if you're, again, let's say you're a pregnant woman or an elderly person, or you're, I don't know, someone who's been diagnosed with cancer, who just has higher metabolic demand to your tissues and capillary beds. You might have an increased ventilation where there's not necessarily a change in your partial pressure of your gases. There's not a change in terms of the speed of uses of those gases. So you're not using oxygen any faster or delivering CO2 any faster. Your partial pressures aren't changing, but your ventilation is slightly changing because of increased demand, and that is hyperpnea. The other two terms, hypoventilation and hyperventilation, there is a change in your arterial partial pressure of your gases, oxygen, and CO2. And this is because your rate of ventilation is not matching the rate of demand. With hyperpnea, that is matching. Okay, it's matching, but it's just slightly increased. With hypoventilation, for example, and this can be caused by several different states, a comatose state, certain drugs and toxins that can depress your respiratory rate. It can be injury to your ribs or to your lungs. A lot of different states can cause hypoventilation. And that would have an arterial partial pressure that is decreased, an arterial partial pressure of CO2 that is increased. So oxygen partial pressure decreases, CO2 partial pressure increases because you are using oxygen faster, delivering CO2 faster than your ventilation rate can match. The other term here, hyperventilation, this is when your ventilation exceeds your demand. Again, it's not being met, which is what's happening with hyperpnea. And in hyperventilation, this can be caused by, again, certain states. For example, exercise can do this. Um, Panic attacks can do this. Stress, certain emotional states can cause hyperventilation. Anxiety, for example. And so arterial partial pressure here is increased. Arterial partial pressure of CO2 is decreased. So you are not using oxygen as fast because, again, your rate of breathing is faster, but it's usually more shallow, right? More shallow, faster rate of breathing to where oxygen is building up in your arteries. It's not being delivered and used fast enough, but PCO2 is decreasing and it's not being produced as quickly because of that shallow, rapid rate of breathing. So here are some of these terms, not something that you need to memorize necessarily. The three that we talked about are important to be able to identify on an exam. So hyperpnea, increased ventilation due to increased demand, hyperventilation, hypoventilation. This is where there's not a match between metabolic demand and ventilation. And then the others are just interesting to know as they compare to those three. So dyspnea, being labored or difficulty breathing. Dyspnea is one of the first chief complaints for folks with lung disease, or any type of lung pathology, respiratory disease. Apnea. Apnea is a temporary cessation of breathing. We can see apnea with things like sleep apnea, right, which can be seen with obesity. Um, and this is another example of a state that can cause hypoventilation. So during sleep, when you have temporary cessation of breathing, that can actually cause hypoventilation as well. Tachypnea is rapid shallow breathing, which is similar to hyperventilation. And then other things in terms of the oxygen use, hypoxia versus hypoxemia. So hypoxia is a deficient oxygen in the tissues. Hypoxemia, deficient oxygen in the blood. And then hypercapnia and hypocapnia are relevant to carbon dioxide, both of these in the blood, okay? Either excess CO2 in the blood, which is hypercapnia, or a deficiency of CO2, which is hypocapnia. So just some of the terminology that we use in terms of states of oxygen, rates of ventilation, the state of breathing, or even delivering of CO2 and oxygen in terms